Okay, good morning, everybody. Welcome to our Neuro Emergency Medicine CME class, which is brought to you by our Neuro Emergency Medicine Special Interest Group in collaboration with the College of Emergency Physicians of Malaysia. So a bit of housekeeping. We are going to have 2 lectures today from 2 very good speakers. So if you have any questions, just drop it in the chat box, and we will get to your questions towards the end of the CME. Yeah. So there are 2 CPD points awarded for this CME as well. So towards the end, you can claim these 2 CPD points by scanning the QR code. So just introduce myself. I am Dr. Gurjit. I'm an emergency physician from Hospital Selayang with a special interest in neuro emergencies. And our topic for today is a hyperacute stroke. So we are going to look at 2 segments. We know detection of hyperacute stroke and out of hospital setting is just as important as in hospital management, because without this pre-hospital care detection, the in-hospital management would be affected as well. So on the pre-hospital care role of hyperacute stroke activation, we have today our speaker, Dr. Umul Khair Mohamad. She is an emergency physician and pre-hospital care subspecialist in Hospital Kuala Lumpur. She's got her master's in medicine in 2012 and completed her fellowship in pre-hospital care and disaster medicine from UITM, as well as University of South Carolina, USA in 2020. She's got a vast experience with many different roles as a coordinator in pre-hospital care, trauma, MERS, and PHC of HKL. She's got multiple awards as well, Malaysian Excellence Service Awards. And she's also got 2 research publications, which is a paper presentation in MinFocus in 2010, as well as a dissertation in CPR in the layperson. Therefore, without further ado, I would like to invite Dr. Umul Khair as our first speaker. Please welcome.
Okay, thank you very much. Thank you, Dr. Gurjit Singh, as our chairman. Thank you to Neuro Emergency Medicine SIG for inviting me to deliver a talk in pre-hospital care role in hyperacute stroke management. First of all, I'm so sorry. Please accept my apologies. Yeah, I'm not feeling well with having fever, cough, and runny nose. So if I'm coughing in between, so I'm so sorry. Yeah. Okay. Okay. I have no conflict of interest to this presentation. So my objectives in my slides is you want to know what is stroke, its type, and how to recognize it. So we have to how to implement stroke care, especially in pre-hospital care, understand the impact of stroke, and to know what EMS or pre-hospital care responder can execute to improve patients' outcome, and to know what is the future of the stroke care in Malaysia. So what is stroke? So it's actually a clinical syndrome. So rapid developing clinical symptoms and all signs of focal, times global, loss of cerebral function, with symptoms lasting more than 24 hours or leading to death. The cause is vascular origin. So stroke is a medical emergency and present with a sudden focal neurological deficit. So most common disease affecting 1 in 4 people during the lifetime. So most are due to the cause of stroke is reduction or interruption of blood flow to the brain. So ischemic stroke is about 80% for the whole strokes. So one of the main causes of death and neurological disability is worldwide. So what is the impact of stroke? So in 2019, so the global prevalence of stroke about 101.5 million people, which by 77.2 million was ischemic stroke. 20.7 million was intracerebral hemorrhage, and 8.4 million was subarachnoid hemorrhage. So how about the death? The ischemic stroke contributes about 3.3 million death. Intracerebral hemorrhage, 2.9 million death, and subarachnoid hemorrhage, about 0.4 million death. How about in Malaysia? So we have a data in 2020. So death in Malaysia due to stroke about 21,000, 21 to 22,000, or 12% to 13% of total deaths in Malaysia. So our ranking is about number 92 in the world. So in Malaysia, stroke contribute third causes of death in Malaysia. Why? Yeah? Because for the first one is, of course, ischemic heart disease, followed by pneumonia, and the third is stroke, and then the number 4 is MVA, yeah? And then number 5 is malignant neoplasma. So why? Because it's tabiat makan yang tidak sihat. Because you know the food in Malaysia very luxury. So we spend about 500 to 700 calories. So this is really burden of stroke in Malaysia because stroke can hit any of each. So 80 to 90% of the population attributed risk for ischemic and hemorrhagic stroke by our food. So less lack of rest, smoking, and so on. So our DG stated that 1 in 4 Malaysian estimated to having stroke by 2040. It's very scary. So how about the risk factor? Is a controllable or non-controllable? So controllable like high blood pressure, high cholesterol, diabetes, tobacco use, alcohol use, physical inactivity, obesity, heart disease, and AF. So non-controllable like age, gender, race, family history, and previous stroke or TIA. So common stroke symptoms, we divide by right or left, hemispheric stroke. So right hemispheric stroke like a slurred speech, dysphagia, weakness or numbness of left face, arm or leg, left-sided neglect, or right gaze preference. So on the left hemispheric stroke like a speech problems, so problem is comprehension, weakness or numbness of a right face, arm or leg, and left gaze preference. So brainstem stroke like nausea, vomiting, vertigo, speech problem, swallowing problems, abnormal eye movements, decreased consciousness, or cross findings. So the intracerebral hemorrhage divided by 2, intraparenchymal or subarachnoid. So the symptoms of intraparenchymal hemorrhage like nausea and vomiting, headache, one-sided weakness, or decreased consciousness. The subarachnoid hemorrhage, the symptoms are worst headache of life, intolerance to light, or neck stiffness or pain of the neck. So we have a stroke mimic, like hyper or hypoglycemia, epilepsy, seizure, multiple sclerosis or hemiplegic migraine, infection like meningitis, encephalitis, or labyrinth. So we have a time is myocardium, time is testis, so brain, so time is brain because every second about 32,000 neurons will die. Every minute 1.9 million neurons will die, and every hour 120 million neurons die due to stroke. So blockage of one blood vessel will cause ischemia within 5 minutes only. So in a completed stroke, we can lose about 1.2 billion neurons. So when you see about 0 to days, you can see the salvageable area of stroke. So it can develop to area of dead tissue if not treated well. That's why every 10 minutes we can save up to 20 million brain deaths if we can detect early. So we go to type of stroke. You have ischemic stroke, hemorrhagic stroke, and TIA or transient ischemic attack. So in ischemic stroke, this is due to blockage of the blood vessels. So it causes a brain cell deprived of oxygen or nutrients. So the incidence of ischemic stroke in US about 83%, and in Asia about 65%. The hemorrhagic stroke because of rupture of the blood vessels. So it causes bleeding into the brain. So the incidence of hemorrhagic stroke in US about 17%, and in Asia about 35%. TIA is actually a time-based, because the acute loss of focal, cerebral, or monocular function with symptom lasting less than 24 hours. This is due to inadequate cerebral or ocular blood supply, because of the atrial thrombosis or embolism. So the neurological dysfunction is because of the focal brain spinal cord or retinal ischemia, is without acute infarction. So we go to definitions. We got actually the hyperacute, acute, subacute, or chronic. So hyperacute we divide by 2, early or late. So early hyperacute is a stroke it's occur within 0 to 6 hours. Yeah, late hyperacute, the stroke is occur 6 to 24 hours. Acute, yeah, normally we say that acute or less than 24 hours. So yeah, acute is stroke that is between 24 hours to 7 days. Yeah, okay. So subacute 1 to 3 weeks old. So chronic when the stroke is more than 3 weeks old. So what is a hyperacute stroke? Yeah, so patient presenting within 6 hours of onset. Yeah, stroke onset. So actually it's actually treatment, whether it's intravenous or recombinant tissue plasminogen activator, when it's treated within 3 hours, or interventional treatments, yeah, mechanical thrombectomy, yeah, when treated within 6 hours of stroke onset. Yeah. So what is our goal in the management stroke patient? To reduce stroke mortality and to improve quality of life. Yeah, is for the stroke patient and their families. Yeah, so minimize the acute brain injury and maximize the patient recovery. So about stroke care, yeah, so actually it's a healthcare activities. Yeah, from the time of first contact, yeah, is a medical contact and a potential stroke patient. Yeah, okay. So patients who show the signs and symptoms of hyperacute in the community must be treated, yeah, as time sensitivity emergency cases, because it can cause a million of neurons die. Yeah, so the patient should be transported without delay to the closest institution or closest hospital that provides emergency stroke care. So we have 8 days of stroke care. So 4 in EMS, 4 in ED, yeah, or in the hospitals. So we go to each type of this. So detections, yeah, rapid recognition of stroke symptoms by community, yeah, dispatch, early activation and dispatch of EMS system by calling 999. Yeah, so our dispatcher will dispatch our ambulance. So delivery is rapid EMS identification, management and transport. Yeah, when the EMS personnel contact to the patients. Okay, door is appropriate triage to the stroke center. So in a hospital, we have a data, decision, drug, and disposition. Data is a rapid triage, evaluation, and management within the emergency department. So decision is stroke expertise and therapy selection, whether the IV TPA or the mechanical thrombectomy. Yeah? So drugs is fibrinolytic therapy or interarterial strategies. So disposition by rapid admission to the stroke unit or critical care unit. So this is a targeted ways, yeah, from MOH to advance the stroke care in Malaysia. Yeah, we see the prioritize the improvement of ambulance services and pre-hospital assessment. Yeah, followed by establish better triage of acute stroke patient in ED. Yeah, so create the stroke care teams. Yeah, to make timely decision of appropriate options where is possible. Yeah, so advocate the neurology consultation. Yeah, consultation services either in a person or via telemedicine. So MOH tried to redesign, yeah, better stroke care by delivery the IV thrombolysis, yeah, as well as thrombectomy, especially in remote areas. Yeah, then provide educate rehabilitation centers lah, yeah, for post-stroke care. Yeah. So when we go to the proficient therapy, is include the pre-hospital emergency services, emergency medicine, stroke neurology, intensive care services, interventional neuroradiology, and neurosurgery. So this is a stroke chain of survival. Yeah? So it's begin of the bystander of community. They aware that the patient itself and all the family members having stroke. So by call for help, yeah? Call 999. So our dispatch center, yeah, in MECC, we have a dispatcher. So they early recognize and rapid dispatch of the EMS personnel. Yeah? So in the ambulance, so the EMS personnel or pre-hospital care personnel, we go to the scene, yeah, to provide the early hospital care and triage to the hospital for early treatment for ischemic and hemorrhagic stroke. So then followed by rehabilitation. So this is a rapid identification by EMS by BFAST, assessment of ABC, yeah, stroke assessment tools, and pre-notification. So BFAST is actually by community. Yeah. So when the patient or the family members having the loss of balance, headache or giddiness, E by eyesight, patient complain of blurring of vision, and one side of a face is drooping. How about the arms? Arms of leg, they feel weakness, and then they having a speech difficulty. So when you have a be fast, so T is time to call for ambulance. So they have to call 999. So when we see the stroke community awareness among our public in Malaysia, so they in 2014 they found that public awareness on stroke risk factors, symptoms, and management is still poor. So why pre-hospital services and EMS is important? Because they are the first healthcare providers in contact with patient that suspect having stroke. So actually, EMS is the first medical contact for most acute stroke patients. They playing a pivotal role in the identification and treatment of acute stroke. Okay. So how about the emergency medical dispatches? From when the patients or the community call 999. So we have a stroke protocol in our EMD protocol in call card 28 is a stroke. So actually in our EMS system, so they found that EMD using MPDS stroke protocol with a high compliance has a high sensitivity than paramedic using CINCINNATI stroke scale. And the dispatcher should spend more time to identify stroke patient. Following the dispatch protocol, they recognize the stroke by dispatch the associate responder to improve the stroke care. So, and then assessment of ABC, so airway, breathing, circulation, they establish the time of onset of symptoms. Airway, so make sure the airway is patent. Breathing, if SpO2 less than 94%, they provide oxygen. Circulation, we assess a patient. We take the vital sign plus the DXT. Then when they establish the time of onset, then they will transport the patient to the appropriate hospital or institution. How about the stroke assessment tools? Actually, it helps EMS personnel to identify the stroke quickly and transport to the appropriate center. So actually, the prostate stroke assessment training, when we have a training for them, it raises the accuracy of stroke identification. So in 2012, so they found that with training, they demonstrate sensitivity about 86 to 97%. And then without stroke assessment training, the EMS sensitivity about 61 to 66%. So a lot of the stroke assessment tools, like a CINCINNATI pre-hospital stroke scale, which is widely used, and then include the Malaysia. So in CINCINNATI pre-hospital stroke scale, so we see the facial, arm, and speech. Facial droop, ask patient to smile. So if abnormal, if one side of face does not move at all, or as well. So brief is when we ask a patient to close eyes, and then extend both arms straight for 10 seconds. The abnormal is one arm does not move or drift down. The speech is by ask a patient to say, saya gosok gigi pagi-pagi in Malay. So the abnormal when patient having a slurred words, says wrong words or unable to speak. So if in CINCINNATI stroke scale, if one of the three signs is abnormal, so about the probability to have stroke is about 72%. The Los Angeles Hospital stroke screen test, labs. So you go by age, history of seizure, new onset, patients was ambulate, and then blood glucose between 60 to 400. So and then we go to examination by facial, by grip, and arm weakness. So this is about few clinical prediction tools, like CINCINNATI, Los Angeles rapid atrial occlusion evaluation, and so on. So most probably, most of the time or widely used is CINCINNATI pre-hospital stroke severity scale because it's simple, and our personnel can do it at scene. So they've found that the CINCINNATI stroke scale, they prefer more lah because a higher sensitivity. So how about the pre-notification? So the our responder should be trained to provide pre-arrival notification. Why? Because can help improve the rapid triage, evaluation and treatment of patient with acute ischemic stroke. The sooner the patient gets to the medical treatment, the greater potential for a better outcome. So this is a pre-notifications. So actually it's initiate targeted, because it's improve the evaluation, timelier stroke treatment, and the more eligible patient treated with thrombolysis. So stroke actually is a public health issue in Malaysia. So EMS providers, so actually they involve and a vital component of the stroke care survival. That's why to increase the knowledge and personal motivation of EMS can reduce death and disability due to stroke, to improve the stroke center's ability to provide thrombolytic therapy and make a positive impact on community rights to reduce cost of healthcare and improve outcomes. So we have My Stroke Hospital to find the stroke care nearby. So we have a responder, we train them. We have a stroke center. So what else? What's next that can help our stroke patients by pre-hospital care? So we how about the mobile stroke unit? Okay. So the data from the Malaysian National Stroke Registry showed that 0.65% of stroke patients were treated with IV thrombolysis in the hospital. Very small numbers. That's why how about the mobile stroke unit? So actually in overseas, there's a lot of mobile stroke unit. So in Asia, we have in Thailand. So since 2018. So actually it's a contain highly specialized staff with trainers, responder, critical care nurse, and CT technologies. So few equipments, and the medication to treat stroke patients inside the mobile stroke unit. So so when we suspect is a is a stroke, so they can do the CT scan inside the ambulance. So they transfer the film to the neurologist in the hospital via telemedicine. And then if eligible to give IV thrombolysis, so our onboard paramedic can initiate the thrombolysis. So this is a sites of active mobile stroke units. When we see the blue side, so in Asia only in Thailand, Bangkok. So they have 8 mobile stroke units all over in Thailand. So now the planning of or implementations of a mobile stroke unit in China, Doha, and others they are still doing. So in Malaysia, actually, we are still in progress, to have a mobile stroke unit is by Hospital UPM. So we hope that they can make a reality to help our Malaysians to save to save their life, to reduce the mobility and morbidity, and to improve the outcome. So in overseas, they have a mobile stroke unit, actually in rural settings. So the advantage of mobile stroke units over standard EMS, so because the result, they average about 100 patients treated on mobile stroke unit, about 27 we have less final disability. So this is my references. Okay. Any question you can ask me?
Okay, thank you very much, Dr. Umul, for the talk. I think the things that were very striking was the epidemiology, the amount of morbidity and mortality, and it's a third leading cause of death in Malaysia. So I think that tells us how significant detection of hyperacute stroke is. And the 8 Ds in the detection, dispatch, delivery, the 8 Ds of a pre-hospital care detection until disposition. We can implement that in our setting as well. And the stroke chain of survival. So a lot of role of pre-hospital care here itself, from the community, dispatcher, ambulance, and then to the hospital. So I think if there is any questions, you can drop it into the chat box. And towards the end of the talk, then we will project the questions to the speakers. So meanwhile, we will proceed to the next talk. Thank you very much, Dr. Umul.
Guruji, can we
Yeah.
settle one because I need to re-record the second.
Oh, okay. Sure.
I think we open up for maybe question first. Huh?
Yeah, okay. So while waiting for the questions, let me have a look at the chat box. No question. So while waiting for the questions, actually, I have a question on my own. Maybe I can start things off. We know that stroke mimics and stroke chameleons is a challenge in stroke patients, hyperacute stroke patients. I believe it will be more so of a challenge in a pre-hospital care setting. What is your opinion on this, Dr. Umul? And how would we tackle the cases of stroke mimics or stroke chameleons in the pre-hospital care setting?
Okay, thank you, Dr. Pujit. So yeah, we have a stroke mimics because we don't want to give a thrombolysis therapy in a non-acute stroke patients. Yeah? So what can we do in pre-hospital care setting? We try to give a talk, CME to our paramedic. In a pre-hospital care level 1, we taught them, to detect stroke patients in our skill station. So by CINCINNATI stroke scale. So plus the DXT. So that from the CINCINNATI stroke scale, from the vital signs, from the examinations. So we hope that our paramedics can differentiate whether this is an acute stroke or the stroke mimic. That's why if they're having a doubt, during their response, so they are we advocate them to call for help. Mean to call the medical director for medical directions, whether this is stroke or not. So if stroke, so we can alert the stroke team lah, in the ED. Even in a hospital, in hospital Kuala Lumpur, so we give a flow chart to our responder. If they think this is a stroke, so plus they did the vital sign, all that, the examinations, the XT, ECGs, so they give to us, the medical director. So we see, okay, this is stroke. So we activate the stroke team as well. We from the MBCC and the emergency physician on call. So they bypass the zone, they bypass the zone to the CT scan. We implement that strategy since last year. So about we can reduce the time about less than 1 hour lah, to get the fully examination by neurologist.
Okay, all right. Thank you. I think you're very helpful. We are going to start a stroke thrombolysis in Selayang soon, so it's a very helpful talk, and I hope everybody can get
and then we wait for we are still waiting for the hospital UPM for them to have a mobile stroke unit. So then the thrombolysis we can advocate inside the ambulance, because Thailand's about 5 years already, So so this is, I think, the better time for Malaysia to advocate the mobile stroke unit.
Yeah, that's fantastic. Any other questions from anybody on the floor? Anybody would like to drop?
Yeah, I have. Dr. Umul, Nasrina here. I would like to ask about regarding the mobile stroke unit kan. The CT scan will be how many punya slices? Will be like 1 or 3 ke 5 ke?
Kalau dekat Thailand tu about 8 slices, because kan kecil kan, 8 slices.
Okay.
So they transmit the film to the neurologist dekat hospital. So they via telemedicine. If indicate to give a thrombolysis, so our responder will give the thrombolysis inside the ambulance.
I see. So, apa tu? I would like to inquire further regarding the mobile stroke unit that is under UPM. So, who will be in charge of it? Will be under UPM or it will be under KKM ke atau like something like a MOA that we sign up with the UPM punya hospital?
If I'm not mistaken, because I will have when I'm having a chat with them, so actually it's under MOE. So if they manage to get the data, yeah, to improve our management of stroke, so maybe later, yeah, so MOH will have a mobile stroke unit lah, yeah. So the pioneer is from the HPPM.
HPUPM lah, because the part that is interesting about HPUPM is they are not really like macam fully, we have to ask whether they got GL and so forth. So we send to HPUPM if the patient has a GL or any
Yes.
financial issue.
Yes, that's why MOH want to see the data first from the
Okay.
HPPM. If a good
Okay.
data, they will provide the good treatment. So MOH we have a mobile stroke units lah. Yeah.
Okay. Oh, that's great. Okay.
Hi, Dr. Umul. Chow here.
Hi, John.
Dr. Umul, I got one question. Do we have a national data like how many percentage of acute stroke actually successfully detected by our MECC as stroke?
Okay, so far we have a data, but we haven't collected it yet, because in the future when we have a National Institute of the Pre-Hospital Care and Disaster Malaysia, so we can include the data, so we can come up with the data. So as for now, we have a data, but it's not published yet. So actually, our paramedic or our respondent, they help us a lot in terms of numbers of the stroke patient. They detect early, so the patients will have thrombolysis. But when in HKL itself, yeah, the numbers of stroke patients, when we differentiate the patient walk in and the patient brought by paramedics, the numbers of patients walk into the hospital with a stroke is higher than the numbers of stroke patient that call 999.
Yeah, I think we are seeing that too in Penang also. More patient walking rather than calling 999.
Yes.
Thank you, Dr. Umul.
Okay, that's why we have to educate our community lah, yeah, how to detect early stroke.
Agree.
Dr. Umar, just related to Charles' question just now. Apart from presuming that ambulance will come late, is there any other factor why they're a bit reluctant to call up the ambulance?
Normally, they can if they having like a numbness of the hand or leg, they will say, "Oh, ini angin," you know. That's why they didn't call 999. They thought it's angin. It's not because of stroke.
Okay. All right.
So and then normally they will call call card number 26, yeah, meaning a sick person. Okay, lemah badan dia tak cakap spesifik is sebelah badan lemah. Okay, ayah saya lemah lah, so is a call card number 26. Okay, so when we dispatch ambulance, so this is stroke, you know. So that's why we have to educate our community.
Kalau untuk stroke tu dia punya call card dia adalah berapa?
28. 28.
Oh, 28. Oh, okay. Yeah. I see. Okay. All right.
Okay, any other questions from the floor? I think if there are no questions, and then thank you very much, Dr. Umul. Very informative talk there. Next, we would like to invite our next speaker.
Okay, can I just stop recording for a while?